Our meeting to order for our August JCC, and we'll ask the secretary to call the roll.
Sure, I'll start with you, Commissioner Chow,
Present.
Commissioner Green,
Present.
and Commissioner Christian.
Present.
All right, I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the July 23rd, 2024 meeting minutes. And I will note a correction that Commissioner Chow asked me to make on underneath call to order. Commissioner Green did not call the meeting to order, so the sentence should simply say the meeting was called to order at 3 p.m. That's the only correction, and there's no public comment.
Okay, great. So we need a motion for acceptance of the minutes of July 23rd.
So moved. Second.
And there being no other, is there any other comment, Mark?
There's not, Commissioner Chow, but because you're remote, I have to do a individual roll call vote. So I'll start with you. How do you vote on this issue, on this item?
Yes.
Commissioner Green?
Yes.
And Commissioner Christian?
Yes.
All right, great. We can move on to item 3, the Regulatory Affairs Report.
Good afternoon, committee, and good afternoon, commissioners. I'm Alex Shoemaker. I'm one of the regulatory affairs nurses at ZFSG, presenting the ZFSG regulatory report on behalf of Emma Moore. So I'll start off with our pending surveys. The first 3 items are CMS outpatient dialysis recertification, the 4A licensing, and the general acute care hospital from CDPH surveys are all long past due. So those have been unchanged on this list for several years, and they remain so. Underneath that, you'll see the italicized CDPH CMS complaint validation revisit. And to refresh our memories, this was from earlier in the year. We had a complaint validation survey within inpatient psychiatry. And during that meeting, or during that survey, both of the complaints were investigated and found to be not substantiated, but there were condition level patient rights findings that were identified, and that warranted a revisit. So that revisit did happen. It occurred in the month of August. That'll be reflected on next month's report, but we are happy to say that the condition was lifted. There were no additional findings cited, and that is now resolved. So we don't expect any other action, and we have received the letter from CMS stating that that has now been lifted. So that will be fully reflected on next month's report, but I'd like to verbally give you that. Any other questions about upcoming surveys or pending survey activity?
There's no public comment on this item.
Commissioners, any questions on the survey report at this point? Did you have more, or you were just stopping here on?
Sorry, I was just stopping partway. I can continue through and stop at the end for questions.
Please.
Thank you. So in terms of survey activity from July, between July 15th and 19th, we had the CMS CDPH, and this is CDPH arriving on behalf of CMS survey of our skilled nursing facility 4A. And so there were several low-level findings identified that included hand hygiene during tray line, cleanliness in the kitchen area, specifically underneath some of the cooking equipment. There was grease and dust that was identified. We had ice machine that had rust identified in the ice bin. There were issues with care planning documentation, insulin injection site rotation, disposal of expired multi-use vials, and behavior monitoring and consent related to psychotropic medication. So independently, none of these were high-level findings, but because of the scope and severity specifically of the 3 findings, the ice machine, the hand hygiene, and it was ice machine, hand hygiene, and the cleanliness in the kitchen, those were all of a scope and severity that warranted a revisit. So it's not a condition that was pulled, but there will be a revisit related to that finding. And so there was a DPNA issued. And so the date for that is October 19th, but we expect to come in compliance with that during the revisit. So we've already submitted our plan of correction. The teams are hard at work. We made a lot of corrections, and we suspect that when the surveyors arrive for that revisit, that we will demonstrate compliance, and hopefully that will be lifted, but we will update you on that as it happens. In addition to the survey, there were 9 facility reported incidents that were investigated during that survey. So they showed up for the survey, but they also initiated investigations on 9 reports that we had previously submitted going back to 2022. And we have not heard back. All of those are still pending. So we are waiting any findings related. Attached to that survey is the life safety survey, also for 4A, but specific to facilities and life safety. There were additional low-level findings, including dust on a fire sprinkler head, a metal gate that was blocking an electrical panel, documentation of a visual fire alarm inspection, testing and replacement of our sprinklers. Because of the age of the building, all of the sprinklers are over 50 years old, which means that they need to be tested. And if they test and they pass testing, then we can keep them for another 10 years. If they don't pass, we need to replace them all. So there's a large expenditure associated with that, but that testing is now in process. And then finally, the fire detection and alarm suppression systems need to be listed in our policy as backed up by the generator. In order for us to be licensed as a hospital, we have to have those on the generator, but that's not necessarily the case for all skilled nursing facilities. And so we need to include that in the policy, and that has already been done. So that concludes the survey activity. We also submitted 1 plan of correction related to a privacy breach that occurred in 2023, and we are awaiting any response from CDPH on that. Moving into cases that were reported in July, we had 7 events that involved 3 COVID outbreaks, 2 HAPIs, 1 RFO, and a privacy breach. The COVID outbreaks were on our 4A unit involving 1 patient and 2 employees, a med-surg unit 5456 with 4 patients and 8 employees, and 7678 with 2 patients and 2 employees. Happy to report that all of those have resolved, and we are no longer submitting any reports to CDPH as follow-up. There were 2 HAPIs. Again, the privacy breach and an RFO. The RFO is related to a sterile glove tip that during a chest tube procedure was left inside of a patient and then later identified. And so all of those have been submitted to CDPH, but we have not heard back from the agency about any of those cases. And that finally brings us down to plan of correction monitoring data. We're happy to report that from the Joint Commission survey that took place in February, of the 82 findings, 70 as of July have completed their monitoring phase. There are additional that have come off of that list after our ALCC meeting in July that we will report next month, but we continue to make progress on those corrective actions and that monitoring. And that concludes our regulatory report, and I'm happy to open up for any questions.
Is there any public comment, Mark?
There is no public comment, Commissioner.
Okay, so commissioners, I can't quite see you, but maybe Commissioner Christian has questions?
I actually did have a question. Can you say a little bit more about the hand hygiene finding? It seems kind of interesting in a hospital that a hand hygiene issue would come up.
So the specific issue was that there was somebody working on tray line within the kitchen, and they were wearing gloves. An item fell onto the ground. They picked up that item. They disposed of it appropriately, but they didn't discard those gloves. And so the corrective action involves coaching and counseling with employees about the importance of hand hygiene and discussions around gloves and this kind of perceived barrier for the user of the gloves, but forgetting that you can still contaminate other items with those gloves once they're soiled. So education has been done, and there's monitoring going on of staff ensuring that hand hygiene practices are being adhered to in the kitchen. So, but it was specific to wearing gloves, picking something up off the ground, and then not changing those gloves or washing your hands as you'd be expected to.
I guess when you're busy on a line like that and you reach down and you just kind of.
I think it was a reaction, and then kind of in the coaching and counseling afterwards, it was recognized as a mistake.
Thank you.
Commissioner Green?
Well, first of all, thank you for the great report. You did a really wonderful job. That was so clear and easy to understand. And I know you had to go through a lot of different items there, so I thought it was wonderful. I did have a question about the fries, and there was, I know there's, I can't find my papers, but I recall there was a graph of 23 and 24.
Correct.
But there was something in the report about having some left from 2022, and you briefly mentioned that. Do we know what's still left over from 2022?
Sure. So that's my mistake. We have an additional page at the request of Commissioner Chow regarding complaints. And so the graph that you were looking at is actually of the anonymous complaints. And so we don't know about anonymous complaints until CDPH comes out on site and initiates an inspection. And so the graph that you saw for 22 and 23 and then leading into 24 is all of the complaint investigations that have been initiated by CDPH. And so I think the summary of that, and then I'll get to fries just after that, is that, where is my complaints? There's 16 complaints initiated in 2023, 6 are still pending, 9 we have received negative 2567s for, and 1 with a deficiency. And then in 2024, we have 7 complaints, 4 pending, 1 negative. If we go back to 2022, that we only had 1 complaint. I think that's attributed to CPH not doing complaint investigations during COVID. If we switch to fries, I did glance at fry data. I'd like to kind of validate that. But over the past 3 years, so 22, 23, and 24, if you go back to 22, we have 60% outstanding fries that are fries that we've submitted to the agency and they have not yet investigated. For 23, that's 88%, and 24 is 92%. So we have a large number of cases out with CDPH that they have not yet investigated.
Well, thank you. That sounds very reflective of some of the issues we faced at Laguna Honda as well. How big is your team? I'm not even sure I know, but I mean.
So Emma Moore is our director. There are 3, I'm thinking on the spot. We have myself, Celia Purdy, and Savannah Tello as full-time nurses. Jenny Tran as our program manager. And then we have, I believe, 3 part-time nurses that also work in regulatory affairs. So it's a relatively small team, but we work well together.
Well, thank you. It's a huge body of responsibility, and the reports are always clear. And obviously, your plans of correction and the way you approach any kind of follow-up is excellent. So thank you.
Thank you.
So I'd like to follow up on those fries again because with our experience at Laguna, it looks like if there are still some fries from 2022 that are outstanding, and certainly your record on the complaints show that they are also behind in those. Perhaps we can have somehow reflected with the fries how many are still pending, similar to what we did actually at Laguna. Obviously there are less, but I think we should be aware of how many, because it looks like even in your complaints of 2023 you still have a number that are pending, and this is sort of astonishing that the state allows that to happen without closure. And it's probably good to have an inventory of what we actually still have pending. So I'm not sure how you want to do that, but you might, in this case, see that I think Laguna came in with a fairly clear way of being able to demonstrate these without getting too, complicated, just in showing. I think we need to sort of have a feeling as to how many are still outstanding.
Absolutely. And I did do a kind of cursory look into it, and just to give you rough numbers, and we'll come back with some validated data and some charts that mimic what we have for the complaints for the fries for next month. But for 2022, 27 of 68 cases were initiated, 11 are still pending, with 14 closed with no findings and 2 identified deficiencies related to HAPIs. For 23, we have 6 of 49 initiated, 5 are still pending, 1 closed with no deficiency. And for 2024, we have 2 of 23 initiated, 2 pending. And the 2 that are pending, the 2 that were initiated, 1 was related to the 4A survey. So they showed up and they did their entire backlog of 4A complaints or 4A fries. And then the other was a privacy breach, which they historically kind of investigate more quickly. So those are the rough numbers. I'll come back with some, or I guess our team will come back with some charts for next month.
Okay, you might look at it, even though Lagunas are a higher volume. I think they've been working in the last I would say charts that we saw seem to be much clearer. Commissioner Green, do you feel the same?
Yeah, I think some of the charts they've done have made it very clear, because there is so much backlog, and it's really helpful to see if any progress is being made. Of course, it's out of your control, but it's somewhat satisfying. And hopefully the reason you have so many pending maybe is that they trust you and they figure they'll find nothing. That would be a way of looking at it anyway.
Okay, if we have do we have any other comments on the regulatory affairs report? If not, we can then move on to the next item, please, Mark.
Thanks again.
Thank you.
Let's see, we can move on to item 4, optimizing patient connectivity, synergizing access and flow across the ZFSG campus. And give me a second to please, so I can pull up the presentation.
Thank you, Mark.
Sure.
Great. Good afternoon, Commissioners Chow, Christian, and Green. Jillian Otway, Chief Nursing Officer, and Dr. Gabe Ortiz is joining us on WebEx, our Chief Medical Officer. We're both thrilled to present our team's work on the strategic driver titled Optimizing Patient Connectivity, Synergizing Access and Flow Across the ZSFG Campus. Today's presentation will give you an overview on the access and flow work that we've been doing and the coordination across all of our interconnected care areas. I'm going to start with our True North pyramid, which helps to center our work. As a reminder, at the top and guiding us are our patients and community that we work for. And again, that is key to everything that we do at the hospital. At the base and the foundation of this work is our True North goals. We will focus on the quality True North goal, but actually, access and flow also touches on the pillars of equity, care experience, safety, and financial stewardship. Next slide, please. Thank you. As with all of our strategies, we develop an A3 document, which helps to guide and direct our work. On the left-hand side, you'll see the background, current conditions, analysis of the problem, as well as our targets identified in benchmarks. And on the right-hand side, we have our countermeasures and our project plan that's outlined. In the remaining time, I'm going to go over this A3 for you in more detail. Next slide, please. So background, why do we care about flow and access? We care because poor access and flow leads to high waiting times, overcrowded waiting rooms and care units, delays in medical care and treatment, poor patient experience and satisfaction, and definitely contributes to inequities and health disparities. Next slide, please. This process map shows a very complex healthcare system at ZSFG. Our care areas are designated by the large pink boxes, and you can see the interconnectedness across the 6 care areas that are identified in the map. KPIs, our key performance indicators, are also designated in the smaller boxes, and by the red color designation, you can see that they are currently off target. We have plans and teams that are in place to address each of the areas that are off target currently. Next slide, please. And to understand the problem and reasons why we are off target, we need to analyze the current conditions contributing to our challenges related to access and flow. There is definitely high demand. ZSFG is located in a densely populated urban area. We have high ambulance traffic, and given the extensive specialty services that are available, this makes ZSFG an EMS ambulance referral center of choice, even when other medical centers in the area may have bed capacity. In terms of capacity and demand mismatch, we have limited physical space as well as staffing limitations that we deal with. And then there's coordination of complex workflows. We provide emergency care, specialized treatments, and specialized care clinic services. And this sometimes can create logistical challenges in coordinating patients' movements. Once admitted, patients sometimes have availability to limited community resources, which can pose a challenge for discharges, especially with patients that have cognitive or functional needs or deficits. Next slide, please. The challenges, as I said, in our current system results in a healthcare system that struggles sometimes to meet the demands for flow. Namely, we experience high lower level of care days, high census. We have boarding sometimes in the ED, ICU, and peri-op care areas. Long wait times for the ambulatory clinic services, as well as long wait times for our operative surgical procedures. Next slide, please. So there are multiple external factors that also impact our care areas. And as listed here on this slide, the economic downturn leads to more patients that may be seeking care at SFGH, the opioid epidemic, impact on Senate Bill 43 and mental health crisis. There's the reduction of services in both external and community facilities, as well as COVID-19. It's still quite real, and individuals that may be experiencing homelessness and other factors. Next slide, please. This slide gives you a visual of the demand for med-surg beds. As you can see, from 2022 to 2024, there is definitely a difference. And this also includes patients that are located in the ED that are boarding and peri-op and maybe in ICU waiting for a med-surg bed. Thank you. Next slide, please. Hence, this is our problem statement, which is that the challenges of excess demands, inadequate access and capacity, and inefficient flow exacerbate the disparities in healthcare delivery. Next slide, please. Our key performance indicators that we have decided and identified as the quality metrics in the relevant clinical areas that are interdependent and fundamental for driving the patient access and flow across the care continuum are lower ED ambulance diversion rates going from 50% to 35%, lowering our ED left without being seen rate to 4%, continuing to improve access to specialty clinics within 21 days, going to 90% on that KPI, as well as continuing to lower our lower level of care rate to 1,100 days. And then obviously, the OR plays a factor in this, and being able to improve our OR add-on completion rate. And we're hoping to get to 95%. Thank you. Next slide. Thank you, Mark. Oh, did I?
No, it's on my, it hasn't shown up on the thing yet, but it's forwarded on my slide.
Your slide.
Yeah, I'm sorry. I'm not
Oh,
sure
there it
how
is.
to upgrade that.
So in addition to the KPIs, there are lots of other PDSAs and work being done to support improvements in access and flow across the organization. This work aligns with the IHI strategies of shaping the demand, matching capacity with demand, and systems redesign. The columns represent the activities in our identified care areas. For example, the ED, Department of Care Coordination, inpatient units, peri-op, 4A SNF, and specialty care areas. I think this slide for me represents the work that's being done throughout the entire organization, which shows that it's not just an ED problem or an inpatient problem, but it's an organization problem, and that we're working on it as a team. We really have, I think, impressive monthly meetings with all of the care areas where they're sharing the work that's being done. Next slide, please. We also have key external countermeasures, which include, I'll let that.
Yeah, it seems takes a little delay.
Okay, thank you. Our Laguna Honda recertification and our partnership in accepting new admissions. We value that, and we're really excited about the work that's being done with Laguna Honda, as well as the San Francisco Health Network CalAIM efforts with the Enhanced Care Management Complex Care Team. They are partnering with us on discharging patients that have complex needs to the community settings. And then the San Francisco Health Network Leadership Engagement on creative solutions to lower level of care issues. And that concludes my presentation today. I'm going to open it up for any questions that you may have. Thank you.
And there's no public comment, commissioners.
So Commissioners, Commissioner Christian?
Thank you, Dr. Let's see, on the slide, key external countermeasures. Is it possible to say a little more about the efforts to partner on discharging patients with complex needs to community settings and creative solutions to LLOC issues? Can you give any insight into what some of those conversations are like? I don't know whether you can at this point.
You know, I'm gonna let Dr. Ortiz, Gabe, are you able to answer?
Yeah, thanks for the
Oh, great.
question.
Thank
Uh,
you.
the partnership with the San Francisco Health Plan in the context of CalAIM efforts and the expanded case management or enhanced case management has been a real boost, I think, to the development of plans for some of our most complex patients. We've had our Department of Care Coordination complex care team sets up case conferences where we invite the case manager to meet with our teams and to think creatively. Sometimes we've had even community kind of resources or use the community resources like SROs or support housing to craft care plans for patients who may be very vulnerable or very incapacitated, to see how we can creatively support them in those community settings so that we can avert kind of needing to wait for some long-term care facilities. And so that's just one example of how we've been trying to partner with the ECM programs that have been stood up to kind of come up with more creative plans so that we don't overly rely on then kind of waiting for some a long-term care facility placement, and can try to return folks to these alternate community settings that might be more available, like a supportive housing setting with increased support and resources. And so that's just one example of what we're working on to try to get some of our most complex patients back out into the community and avoid institutionalization. And there'll likely be more as we think creatively about the lower level of care root causes or the contributors to the lower level of care issues, and kind of how each patient's profile may reflect a kind of differing, might call for a differing approach to being able to support that person outside of the hospital. So more to come as we dig deeper into what might be available for mobilizing and for trying to reduce these days.
So alternatives in part to resources that are lacking. Like if somebody ordinarily the first thought would be, well, let's send them here, but we don't have enough of those beds. We don't have enough of those resources. And so you're getting together and talking about what else can we do? How can we serve this person in a different way, in a more creative way?
That's correct. That's exactly right. And the ECM programs have been really instrumental in terms of that partnership for kind of thinking creatively. Sometimes our ECM partners have access to certain resources or can commit to being part of that plan so that teams and community placements feel more comfortable with the patient actually leaving the hospital and giving them a trial of this extra support in this community setting.
Do you find that sometimes you end up kind of creating new pathways and new resources in an effort to find a different solution for the person and a solution that actually exists? I don't know how often that might happen.
We've definitely kind of been putting on the thinking cap, so to speak, and trying to think outside the box. For example, we had a patient who had issues with community navigation and was frequently getting lost in the community, wandering even to other counties. And he was kind of agreed to wear an air tag and kind of that reduced the patient getting lost because the teams were able to find him and bring him back. And so kind of creative solutions like that allow us to, where previously kind of folks felt uncomfortable supporting the individual, kind of coming up with creative ideas to meet the patients where they're at, meet their needs, and use what we have, mobilize what we have to be able to help to support the patient and in support their autonomy and independence for a bit longer.
It sounds like every member of that team is really important, and the case managers especially, being so close to the person, really important that we continue to have and support excellent case managers in the community. So thank you for the response.
I think that I just follow that as a question before we go on to Dr. Green. The lower level of care census that Dr. Ehrlich has presented to us, and which you'll see again, shows that back in 2022, we actually had 30 custodial, and now we have 68. So meanwhile, we've had this A3. So I don't know, because many of the issues that you raise, and this is just one of them. I mean, we've seen movement on diversion and everything, but I'm not sure how much more creativity that we have unless you're really able to have added capacity under your post-acute block. And we've heard this maybe each year, that and each year this number continues to go up in this historical quality record that we have here. So what is new creatively? You can write goals, and this is really a stretch goal to go from 2,000 to 1,000, really, and it's probably the hardest goal, because much of it you don't really control. But what has the group been able to do to really, or what does it need in order to create more? Because the mayor's office keeps telling us about all the new areas that have been opened.
Yeah, it's a great question. I think we really felt the closing of Laguna and kind of their going offline. They're kind of one of our strongest partners for mobilizing patients who have custodial needs, but are their needs are too great to be managed out in the community. So the rising of the tide there in terms of our lower level of care numbers correlates tightly with kind of not having Laguna as an option for some of our most complex patients. So that will we will be interested to partner with Laguna as they become ready to receive patients from the general in the wave 3 of their kind of reopening plan. We'll be tracking how we can best partner and identify patients that will have the biggest impact to the lower level of care rise that we've seen over the last few years. In addition, I think kind of digging into the numbers to kind of take advantage of new programs that didn't exist before. So speaking to CalAIM and the ECM programs, kind of hoping to chip a little bit off of the lower level of care numbers using that strategy. And then kind of continuing to structure our data in such a way that we have better visibility of what are the true needs of our patient population. So just last week, we released an update to our electronic health record to more granularly define the discharge disposition for our patients. Previously, we had CMS codes that were less useful, and now we have real world nomenclature, like our patient went to medical respite, or they went to a hummingbird or a navigation center or a shelter. So we're going to have much more granular data, easier to pull, and kind of structured data to be able to quantify where are patients going, what are their needs, so that we can more effectively advocate and kind of look for the resources. For example, if it is truly custodial facilities that we are in need of, or if it's more IHSS services that we're in need of, we're going to be in a better position to be able to make that case or to quantify the need so we can advocate for any additional resources. And so you're right, Dr. Chow, that the number, it is a stretch goal. I think we really felt the lack of the disposition option that was Laguna, and that we're hoping to partner really strongly there. We're hoping to take advantage of new programs like this, the ECM program, and really have institutionalization of our patients who are really complicated, be the last option of choice, and really think hard and creatively about everything short of that to support folks in the community. And then finally, kind of let's learn as much as we can about our patient population so that we can advocate for what it is we need moving forward.
Well, thank you. I know it's a very tough question, and you're right. Some of this correlates with Laguna, but then again, it has to be the right kind of patient who goes over there too. So, as you're studying this, there may be some patients, and it's not actually on this list, who may have substantial mental problems or abuse problems that don't fit any of these categories. And that just brought up to my mind that there are additional post-acute issues that are not really in your block there.
Yeah.
Part of that deals with that whole the state psychiatric issues of access and all. But I think as you define it better, and as we look at this better and start parsing it out, this actually is the bottleneck for all these years. Because
That's
if
true.
you were able to reduce that lower length of stay, we'd get back about 100 beds or so, right? And
You're right.
and that would be a great help to all of this in terms of the backing up all the way down to the ER and the borders. So
Absolutely.
this
I call it the elephant in the room.
right. So but I do think the mental health component needs to be in your pink block, because I think that's a real issue as to these patients can't really go anywhere. And as we know, if that is the primary issue and not really sniff care, even Laguna will not be an answer to that unless we restructure Laguna.
And that reminds me of one of the questions submitted in advance with respect to the the impact of SB 43. And I asked our experts, Mark Leary, our chief of psychiatry, and Janae Bryant, who's one of our expert complex care social workers, about kind of what has been the impact of SB 43 since it went live in January. While we haven't seen a huge number of patients that are in the hospital related to SB 43, the small number that have been stay for a long time and disproportionately contribute to an already overcrowded hospital, not just in the acute medical units, but also on our inpatient psychiatry units. So we had felt an impact of the legislation. One of the measures is kind of related to temporary conservatorships, and we've seen a net increase of temporary conservatorships of 43 compared to this time last year. So we're seeing more temporary conservatorships. We've seen kind of more patients referred to the hospital, even if it's not a large number. The small number that are referred for placement, and we've had a really tough time placing those. Our complex care social worker said she's been tracking these SB 43 patient cases very closely, and none of the patients that were referred initially to us on SB 43 reasons got placed. And so we're sending these folks back into the community using these creative solutions that were described through case management and other kind of partnerships with community partnerships. So time will tell. We'll keep watching this very closely, but it has certainly had an impact and has contributed to an already full kind of system of care.
Well, thank you. Commissioner Green?
Yes, well, thank you. This is a wonderful, the KPI and key driver diagram, so clear. I was wondering the extent to which you're able to use software programs to kind of analyze some of this, whether it's OR utilization, or in particular, I know there are some around the country where you can find resources for all of the social determinants, including food insecurity, in one place. I may be misunderstand it because it is so complicated, but we have a handle on certain types of beds that are available. But then there's that whole additional degree of support that many of these people need. And it sounds like our case managers, is there a central repository, or is each one of these patients so unique? I'm just wondering if there are any solutions that would accelerate things and make the individual research that the case managers have to do, would unburden them in some way. Are these types of things available that we can look at, whether it's systems within the institution? I know some have used it for staffing, for example, and then the bigger picture of the placement issues, because it's not just a place to live. There's so many other elements involved.
I think definitely Epic has played a huge role in this and being able to, for the case managers to have access to all of the information that's needed. And again, to your point, with the social determinants of health, that's done on admission when the patient comes in through the assessment tool with the nursing staff. And so this is something that we know from the moment the person has been admitted, and then we're able to start to address a lot of these issues on the front end. And I know, I learned in school that discharge starts on admission. From the moment someone enters into the facility, that's the moment you need to start talking about what's the disposition, what's the final outcome here. And definitely with the OR, there are a number of tools that they use and they have available to them. We got a really great report on Monday from the OR team that highlighted all of their data in terms of on-time start, their block utilization, as well as level loading of the come and stay cases that they've been doing the work related to that. And then we're going to be opening a 9th OR in October. And so we were able to learn about how that will probably help to improve our ability to be able to get to all of the add-on cases that may be waiting, that again are taking up a day or two in the hospital.
Thank you.
Are there any further comments from anyone? If not, then
Dr. Chow, I do have one. So thank you for this amazing report. And I'm looking at the key driver diagram and, the information you've given us about discharge and the creative solutions you're looking for in the community. And this is probably more a comment than certainly not a question for you, maybe at a stretch, Dr. Ehrlich or Grant, Dr. Colfax. But so, we've talked a little bit about the impact of SB 43, and I'm thinking about the mechanism that may not exist right now, but creating a mechanism to give feedback to the legislature about the impact of the legislation that they pass. Very good legislation, but the impact of it on the community, a public hospital like General. And Dr. Colfax, do we have something, a path like that? Is that kind of communication, does it exist?
So as you know, we are one of just 2 counties in the state implementing SB 43 because of the complexity, the heavy lift, and the resources necessary to implement SB 43. The other county is San Luis Obispo. So we have at Mayor Breed's, or Mayor Breed issued an executive order to have an SB 43 working group where we are gathering data, analyzing it, meeting every month to go through it, working closely with the conservator to see what's working and what's not working around SB 43. That information will be provided to the state, and we are in contact with the state on a regular basis to let them know how it's going. I would say that, as you're hearing here, there are multiple issues around hospital census, and Dr. Ehrlich and the others in this room know better than anybody around this. I think one of the key other areas that is a challenge, and Dr. Cunnins has emphasized this as well, is the lack of capacity of block beds in the state.
Mm-hmm.
And one of our messages to the state is that really it will take state leadership and state policy to help local jurisdictions realize the potential SB 43 in expanding the possibilities of how to create more locked beds. I was just at St. Mary's at the Healing Center, which is, I think as the commissioners know, 54 locked beds. That was a partnership done with St. Mary's, UCSF, and DPH. More of those partnerships need to be supported, and the infrastructure that really only the state could support and the policies that really are needed for regional collaborations really need to be scaled up in order to realize the full potential of SB 43 and to help decrease the hospital census in so many ways.
Thank you so much for that information. I'm very, very glad to hear that. I'm not surprised, but I'm very glad to hear what the pathway is. And, and as always, if there's anything that we can do to support the work that you're doing and the communications that you're having, please let us know. It's just everything comes down to that. You're looking for and finding creative ways to get people where they should be rather than where they are because we don't have enough resources. But ultimately, this is, it's just a shell game and creative thinking and getting people back to homes if they have them with resources. So thank you for this really, this work. And I'm sure it must be very frustrating at times, but thank you for it.
Commissioner, can I just add one more thing to that?
Please.
I know I went a little bit long there, but I do think the other part that needs to be said in our fiscal, in our fiscal situation is, one of the other places where we are doing everything we can locally that, there's been a huge amount of support for bed expansion. Mayor Breed has expanded beds, particularly around lock beds. Medicaid doesn't pay for lock beds. Just as an example, Medicaid doesn't pay for lock beds, so the general fund and the cost for lock beds is substantial. And again, this is an area where other jurisdictions who are not as generous with their general fund don't have any potential for paying for lock beds. So that's a policy decision that, again, is very impactful in terms of our ability to realize Prop 43. And another reason I suspect that of the, is it 53, 52 counties in California, only 2 have moved forward with SB 43 implementation.
Thank you so much for that information. The only other thing I wanted to say was looking at the diagram, hiring of nurses, RNs is a feature of just about everything here. And I wonder if that process, if this is a forward-looking process more than something that's also going on now. I know that we get the HR reports about the hiring reports.
We have done an incredible job in terms of the work of hiring and being able to onboard and reduce the time that it had taken us a year ago. And so we are starting to feel that now. And what I've always said is, it's not just about the hiring, but once you bring that individual into the organization, you have to support them and to train them. And so you may not see the fruits of that initial hire for at least 3 to 6 months and maybe even longer. Again, I was at the huddle board today in ED, and they have the lowest vacancy rate they've ever had. We've never experienced this before. It's really been very impactful for us. We have an event scheduled on the 14th of September with our HR partners to, in anticipation of the new FTEs that we're getting in October. And we want to be really proactive about it and not respond, in November, which, we've kind of done this in the past. I'm not going to pretend. And so we're going to actually not only host experienced applicants at the hospital on that Saturday, but also provide them with a date and time to come and interview the following Monday, Tuesday, Wednesday. And then by Thursday, Friday, we'll have requests to hire packets in, which again is, being really proactive and hiring into the 45 plus positions that we're going to have available to us in October. So the hiring has been very impactful. I mean, that's the foundation for everything that we do. I think the next steps, and we've talked about this with HR, is that we need to now take the lessons learned and then move that forward to the other classifications, because it takes a village. It's not just nursing. It's the PCAs, the MEAs, social workers, the nurse practitioners. We have vacancies in these areas that have, we can actually see that, oh, this is a problem for us. And so I think that'll be the next steps in moving this improvement work forward. How can we spread it?
Well, great plan. Thank you so much for your work. It's incredibly great. And thank you also, Chief Ortiz.
Oh, well, thank you.
Dr. Ortiz as well, for being here
Great.
with us.
I want to also congratulate our new director of nurses, who, of course, we've known in her current role for over 2 years already, and of course, Dr. Ortiz now in his new role as CMO. This is a very nice presentation of your A3, which certainly captures many of the issues in one place that all of us have been facing, and makes it so clear. As you say, the elephant in the room is really that last block. Has been for a long time, and I think it's very clear where our entire budget is really impacted by those nearly 100 people who are needing another place. So really, thank you for this presentation, and I think a follow-up showing where you have gone would be very helpful in an appropriate time, maybe half a year or something, because it's different from all of your scorecards. I mean, this really continues to look at that elephant. So thank you very much.
Thank you.
Thank you, and Dr. Ortiz, thanks for joining us.
All right, shall we go on to the next item, please, Mark?
Speaking of budget, what a great transition to our next agenda item. Good afternoon, Commissioners, Dr. Colfax, Mark Morowitz. Hope you're all doing well. I am Eric Wu. I'm the Chief Financial Officer, and beside me is Dr. Hemel Gazaria. He's our Chief of Performance Excellence. We're the co-owners of the Revenue Cycle Optimization A3. This afternoon, Hemel and I are excited to showcase the work that we've been doing in the area of financial stewardship. Our focus has been on ensuring responsible management of our financial resources, and we've been working diligently to refine our approaches and drive meaningful improvements. So today, we are excited to present the status and outcome of some of these efforts. Next slide, please. I'll start with our True North Pyramid to center our work. As a reminder, at the top and guiding us are our patients and community. At the base and foundation of this work is our True North goals. This afternoon, we will focus on the financial stewardship True North goal on the bottom right corner of the pyramid. Next slide. Okay, perfect. As with all of our work on our True North metrics, we've developed an A3 to help guide and direct our work. On the left, we have our background, current conditions, and analysis of the problem. We also have our targets identified and our benchmarks set. On the right, we have our countermeasures and project plan outlined. And in our remaining time, I will walk you through this work. Starting with our background, we see at DPH and the network, we've been actively exploring financial models to better support our community and manage the high cost associated with out-of-network care. We used to use a capitated payment model for hospital services for our consortium clinic patients, and then discovered that 50% of inpatient specialty at ZSFG were actually already on the fee-for-service model. We used the consortium clinic patients as kind of our initial focus group for our conversion to fee-for-service and leveraged our experience to expand fee-for-service as our capitated payments became less than what we were receiving, what we were paying for in out-of-network costs. The shift to fee-for-service requires a more rigorous authorization review and denials management process. So without an accurate and complete management, we risk losing significant revenues, both for ZSFG and the health plans we work with. So ensuring proper payment for the services we provide is critical. So this requires a focused effort on improving our processes in these areas. Moving on to the next slide, our current conditions. So with this background in mind, our current conditions for denied claims we were observing before our fee-for-service conversion was at about 14.5% for hospital billing, excluding self-denials. However, after our transition to fee-for-service, our baseline denial rate increased to 18.6%. This rise highlights and emphasizes the need for more robust processes to address the complexities introduced by the fee-for-service model and to reduce our denials and ensure financial stability for ZSFG. An example of these complexities, you'll notice a spike in our denials rate in June. This increase was due to the transition of PES from Avatar to Epic billing on Medicare. Our teams are actively looking at this issue to mitigate further denials. Additionally, we also started billing for observation services to the SF Health Plan, which is also contributing to the increase in denials. The team is working with IT on making payer logic updates to prevent future issues from occurring. We are confident that our ongoing efforts will ultimately strengthen our billing processes, enhance overall efficiency, and improve patient care. Next slide, current conditions. Our baseline hospital billing denial rate for acute stays and outpatient specialty procedures was started at 18.6%, as I mentioned earlier. We set an ambitious goal to reduce this rate to 15.6% by June of 2024. We are pleased to report that through focused efforts and improved processes, we've made significant progress, bringing the denial rate down to 16%. While we still have some work to do, this reduction demonstrates that we are on the right path. And I'll pass over to Hemal.
Good afternoon, commissioners. Nice to see you. Hemal Kanzaria, Chief for Performance Excellence. So our problem statement from this A3 was that our current ZSFG clinical and financial workflows resulted in denied claims and lost revenues, which certainly impacts our true north outcome of financial stewardship and ultimately our ability to be the best hospital for our community and our patients. You can see the nice schematic around the problem statement, around registration, charge capture, to coding, billing, and reimbursement. And clinicians interface with this process throughout in terms of, for example, putting in CPT codes correctly for the procedure that you're going to perform. For example, documenting accurately, comprehensively, to sort of get credit for the work that we're doing and for the care that we're providing our services. Denials can come up at each of those steps. And so this past year really has been about digging deep and really understanding more about denials. Next slide, please. So a major countermeasure from this past year has been the formation of the Denials Task Force. This is a large multidisciplinary team that includes staff members that are all across DPH, including patient financial services, the revenue integrity team, our HIM staff members, our Department of Care Coordination staff members, and clinicians as well. So this is a relatively new team that historically hasn't come together and seen the process from beginning to the end. And so a lot of our work this past year has really been mapping out the process from beginning to end to understand what a claim goes through from the beginning to the end stage, and then where defects happen along in that process. We've worked together to understand what the main contributors to denials are, and then why they happen. So we can go to the next slide. So a lot of work is coming out of this. I can report that sort of to answer some of those questions. The main contributors to denials get at a lack of medical necessity or sort of inappropriate level of care. That's sort of our biggest bucket. That also includes a range of items. So for example, patients who have really complicated social needs, who don't have an acute medical need that meets CMS criteria for hospitalization, but there's not a safe place in the community. It includes placing patients at the wrong level of care. I think last time we talked about sort of observation services, and one of our main countermeasures this year has been to expand our approach to observation services. We went live with Medicare beneficiaries in 2019 with Epic's Go Live, and it was a brand new process for us at the General. This past February, we went live with Medicaid beneficiaries from the San Francisco Health Plan, which is one of our main payers. And that is sort of an innovation that's brand new. And so those are opportunities for us to not have denials for the care that we provide, but to actually get reimbursement from those patients. Another major contributor is lack of prior authorization or appropriate authorization. And these can sort of be either not doing the authorization correctly or anticipating you're going to do a certain procedure, but maybe there's something that changes. And so again, getting that process correct and working with the health plans around that. It's also involved a lot of partnership with the San Francisco Health Plan on these new processes, as well as giving them real-time feedback on whether sort of IT and systems issues that we're picking up and that are sort of erroneous denials. Those are currently contributing to our denials rate. We can go, the pictures on the slides are that they're quite small, but I wanted to highlight something that I feel proud of, and I'm biased, but the integration of performance improvement and lean data tools to this team. So the picture on the right is a first drafted a countermeasure summary, which is a commonly used tool to really dig into, what do we know about our problem and our data to date? How do we stratify that data to understand it better? What are the root causes of that problem? And then what can we adjust and do about that problem? So this is really in the last month or two, the first time we're using these tools in this team. The bottom diagram is a depiction of a sort of driver diagram. I think that in the past presentation, we saw an equivalent of that. This is in an Excel file where we highlight, here are the big buckets of denials. Here's how often they happen, how many millions of dollars they're costing us. And then here are the departments and the people that are involved and the countermeasures that we're trying to address that problem. So very sort of systematic. Next slide, please. I put some of the achievements from this work here. So I mentioned sort of the expansion of observation services. We've also done a pretty deep dive in collaboration with Dr. Ortiz and Jillian and others about our approach to patients who need a joint replacement. Those are currently individuals who are not getting sort of credit for the work we're doing. We're not getting reimbursed to the extent that we would anticipate. We have also brought on an amazing new HIM director, Mary Holloway, who brings an incredible amount of expertise and energy and passion for this work and is teaching us all. I mentioned some of the integration of improvement tools. Again, here on the right, you see what's called a swim lane exercise, where we brought all of those disparate teams together. And what I understood from that was the first time many of those team members have met each other in person, because they're working, sometimes remotely or sometimes across DPH. And part of this has been sort of team building and alignment on our strategy. So next slide. I want to acknowledge that we are also at a transitional time with this strategy, where while we initially focused on denials because of our transition to fee-for-service, there's also many reasons to think more broadly and recognize our current sort of fiscal situation, recognize other opportunities to increase revenue. And so Eric and myself and the team have been going back and really thinking about, from a strategic lens, how do we capture the work that needs to happen around financial stewardship? And so I anticipate, in the next couple months and coming back here, there will be a updated A3 that will be inclusive of denials, but will be expansive beyond that. And we put some of the key performance indicators that the team is considering and that we're starting to look at the data, and we'll be starting to work on together and move forward. So they include things around documentation, for example. They include things around revenue generation. They include things about capturing the benefits of the expansion of the OR. So those are just some examples of the types of work that we're going to be pursuing over the next year. And with that, I just wanted to say thank you, and we're happy to take any questions.
There's no public comment for this item.
Good. Thank you very much. And we'll start with Commissioner Green first. And I know she had some extensive questions and and don't note the responses that we have gotten, but perhaps she'd like additional opportunity to expand on this.
Well, thank you. This is really complicated work and it's challenging, I know. Can you clarify what percentage of your payer, who your payers are? In other words, how many of these individuals, especially with the denials, are our own health network versus other payers? I mean, where is this coming from largely?
80% of our patients are from the health network.
Or what?
80% of our patients are with the health plan.
With the health plan.
Yes.
And have we, what's really frightening to me is that we're seeing a huge number of denials and requests for more information. And apparently quite a few plans, and this may not be our own, but are using AI and they're just plunking out denials. And we've been given an estimate that within a year, 35% of our claims could be denied. Because there's obviously, if AI is doing it, there's no employees involved and it's just, touchless to, dump all the responsibility on the providers. So I'm wondering whether, I know there are companies that do this, as their expertise. Have we gotten any consultations from the outside that might save you some work in terms of the analyses? Because I suspect there are common threads in this among the various plans, regardless of who the payer is.
Yeah, I think it's a really important question. I would say there's, Eric was actually just sharing an example earlier today with me about a payer platform that many other payers use for some of these processes with the health plan. And we've, approached them several times about this that would help us automate the authorization process and reduce our denials. But it sounds like right now we're still working on a partnership with them that would allow for that payer platform to be used through SFHP. So that's an example of technology that I think would benefit us. That my understanding from Eric is sort of industry standard, but that we don't have available to us here. In terms of AI, I think that's an area of interest to our team to explore. And we have an amazing sort of group at ZSFG led by Dr. Lucas Zier that's focused on AI and machine learning for performance improvement. And so over this past year, we have been working with that team to align specifically to some of the strategic work. And so you'll hear at another date the work they're doing around patient safety and sepsis. And our rev cycle strategy is definitely, I've talked to Dr. Zier several times about how their team could be helpful with the work we're doing. I think there's a huge opportunity, and I agree. I think that's something that we need to continue to explore. I don't have details we haven't moved forward with it to date, though.
And when they denied joint replacement, I mean, what was their excuse? Are there any common reasons? It seems like that would be an odd one.
Yeah. So obviously it's more complicated than I want it to be. I think part of it is administrative. So it's ensuring that we are admitting patients to the right level of care based on CMS guidelines. So that comes up for certain subtypes of our patients, including common procedures like APPEs, for example. And so I think this is a relatively new process to recognizing that, even though someone needs to come in, they need to be on IV antibiotics, they need a surgical procedure, they don't meet CMS criteria for using a hospital stay. So some of that's administrative and getting the correct level of care for those patients. For joint replacement surgeries, again, Medicare does not consider joint replacements an inpatient procedure. Many of our patients, because of a number of physical or behavioral or social vulnerabilities, it's very hard to do rehab when you're unhoused, for example. And so, I think our teams are mission driven. They're trying to do the right thing by the patient in front of them. But that means that we don't get paid for the services that we provide. There is still opportunity for improvement, and we need to identify folks that we can still deliver the care that they need and align with Medicare guidelines. But I think we do have, we have challenges that safety net systems face around this issue. But that means that we don't get reimbursed for a huge proportion of the surgical care we provide to those patients.
Well, it's like what Director Colfax said about the locked beds. I mean, you're trying to help a population of individuals with huge challenges, and you are financially penalized for making that effort. What with the observation status, now this is something I've been wondering a little bit about, because on the one hand, if you put someone in ob status and they bounce back in 30 days, you don't get dinged like you do if you admitted them. On the other hand, I believe there's some stipulation where if someone's only ob status, they may not qualify for some services once discharged. I don't know if that's just Medicare or that applies to Medicaid as well, but I know there are some individuals, for example, I know some examples of people who have been on ob status for 5 days with stroke and really need rehab services, but because they were only obs, they were Medicare, they did not qualify for the post-discharge skilled nursing care that they needed.
Yeah, that's a great point. I know the first half is definitely true in terms of there's some amount of gamesmanship with the readmissions pathway that I think, again, like our team, we're trying to figure out the right thing to do for the patient in front of us. And I know that there's a lot of literature around that. You know, there are subtypes of patients that are low acuity and there are clinical guidelines for things like PILO or like, you know, pain control or like TIAs. And then I do think we get into a tricky situation where patients need those services and may not be eligible for them. I think I'll have to go back and look with joint replacements or APIs if that is true or not. I think I'm not sure if the same thing is true. I can definitely imagine that for patients with a stroke, though. Yeah.
Yeah, it's tough. Is it can we do with regard to advocacy? Because there's so many things, as you know, you listen to what's compensated and what isn't, that seem um, uh, the opposite of what should happen. What kind of political impact?
I think
And I mean, I'm sure DISH hospitals all face the same issues, but is there any way to change the lens through which Medicaid views these things?
I think there is some hope, and we've seen that with CalAIM in terms of recognition that social factors influence, you know, our patients. And so the fact that we can now get reimbursement for, you know, patient navigation or housing navigation services does give me hope. I think for Medicaid reimbursement rates, I know that there's a lot of advocacy around it, and it feels woefully inadequate for sort of the services that are being provided or what our patients need. And I mean, I'm sure that Dr. Ehrlich and Dr. Colfax can speak at a really intelligent level about what can be most effective locally for us. I think the things that we can be most successful at are partnering with our local Medicaid managed care health plans and highlighting where there's not adequate network access, for example, for skilled nursing facilities, or we're not getting reimbursed for, significant patient needs and patients that need care. And so when our denials lead is, connecting with them and giving them real world examples from last week that they can look up and problem solve together, I think that helps sort of nudge us forward, even if it's just a start. I don't know if there's other things from a financial lens.
Well, thank you so much for this advocacy work, and it's a uphill battle, but your challenges are vast, and we really appreciate all the work you're doing to try to rectify. So thank you.
Thank you, Commissioner Christian.
Thank you, Dr. Chow. Thanks for the presentation. You're talking about denials at the general, and I'm thinking of denials that I've experienced as a patient going to my health plan, which is one of the ones that you're dealing with. So it's interesting to think about the levels of denials. On page 9, you talk about advancing ongoing PDSAs. And this is probably not the only place where you talk about observation services, but can you explain to me what observation services are and what it means that you are looking at expanding them?
Yeah, thank you so much. So observation services is a level of care. There's an administrative component to it, and it's supposed to designate patients that we anticipate need some continued diagnostic or treatment services, but they don't typically require the over 48 hours that Medicare qualifies as needing an inpatient level of care. So they're patients who come in, like I was saying, with, wounds that need IV antibiotics, need, a CT scan, need monitoring, plastic surgery to evaluate, but they may not need to be in the hospital or in an inpatient setting for over 48 hours. So that typically, they can't just be discharged straight from the ED, but they need continued management until we can decide if they're sick enough to need to be admitted or safe enough to go home. That's sort of that observation services. Some systems have observation units, which is like a physical location, and there's a whole literature on observation clinical medicine for things like heart failure or COPD, where patients get treatment, they might go home after getting their initial treatment. So that's really what observation services is. The expansion is because we have focused on Medicare beneficiaries for the first 4 to 5 years of this effort. And in the last 7 months, we have expanded that to Medicaid beneficiaries because we were having denials from SFHP. So we focused with them. They agreed to basically create an observation service pathway that we could get reimbursement for those types of services.
Thank you. Be a fire somewhere.
I really appreciate the work that you've done here. I was wondering that one of the denials can be number of days in service. Does San Francisco Health Plan, particularly since that's our major player, have concurrent review and discuss that with you in terms of their denials?
Yeah, so both our case management teams and I believe San Francisco Health Plan, but can confirm, but I know internally our Department of Care Coordination Utilization Management teams, they review every single patient in the hospital every day to see if we're meeting sort of interqual guidelines, it's a tool that we have embedded in Epic that helps us, say, okay, because of X, Y, and Z, this person definitely does meet inpatient level of care for another day. Or does not, and then we lower them from that. And then there's clinicians that are involved to secondarily do that review. And that happens on an everyday basis with our Department of Care Coordination team members. I believe that is the case with the health plan, but I will have to confirm.
So if in fact our own coordinators say that someone doesn't require acute level of care, then do we stop billing, or do we consider that if they stay longer, that's considered also denial of payment?
Yeah, so that's where that lower level of care number comes from, is we transition them to a status where we're not being reimbursed for their care, even if they are still in the hospital setting.
So, do we keep that as our number, saying that then these are denied even though the patients are here? I'm just wondering, in your then some of the denials are really for lower level of care that we've already agreed are lower level of care.
Yeah, so those are denials that we have sort of self-declared that, this person does no longer meet acute medical needs. And so we have lowered them ourselves. So you're right, I consider them as part of our sort of self-denials. There are times where we get a real-time denial of someone in the hospital setting, and we get a denial from the health plan, and then we have the opportunity to appeal in real time. And so you maybe heard of those as peer-to-peer appeals. And then there are other times where our utilization manager and medical director can get involved both retrospectively and in real time to assist with that process.
So is that a reason that you would say in your charts here that you would expect something like a 15% denial rate that included lower level of care that you yourself had agreed?
So lower level of care is part of the first bucket, the level of care denials, which is our biggest bucket. Yeah, I believe that it is part of it, although I will say for patients we self-deny, they should not be in that category. And so I'll have to go back to the team and just clarify for you what component of that is lower level versus the self-denials that are also lower level. So Eric and I can follow up on that.
Yeah, I think we need to differentiate so that we know that, your target is set that you know, because of all these other circumstances, they don't meet a definition, which is different than from lack of authorization or a disagreement with a plan or something concerning a concurrent care. And I guess the other question is, how successful have you been in challenging those that are not ones that we believe are lower level of care, but are really acute care that you've been able to recover? Because I think that's a important number to have also.
Yeah, that's a great question, and one that Eric and I have been asking. And my sense is actually, while we're reporting the primary denial rates to you here, there's actually a significant amount of work that gets that down further, and we're still trying to get data on what that end result is. Recognizing it takes a lot of work to get to the end percentage, but our understanding from the team is that it is lower than that 16% of denials after we do the appeals and petition, but we haven't yet gotten the specific data on that.
Okay, yeah, because I think that that will help understand how effective your teams have been. I mean, there's a block we can't do anything about because of all the other issues that were raised at our last presentation. But then for those that actually deserve to be reimbursed, how well are we really doing? Because that's really the essence of the optimization, right?
Yep.
For here, and I think that would be an important data point to have at our next presentation when this comes back.
Thank you so much.
Okay, thank you. If we have no other questions, give a moment. No? Shall we go on, Mark, to our next item?
Sure. Thank you again, presenters. Item 6 is the CEO report, Emergency Department newsletter and BERT newsletter. And Dr. Ehrlich, I'll let me know when you're ready for the slide.
Sure. Good afternoon. Wow, it's a lot of information that we've heard about this afternoon. I'm going to add a couple of points that I just want to make especially related to the lower level of care. But before I start in on the report, I just wanted to extend some gratitude. First, to our quality team. You get to see the incredible reports and hear the great presentations. What they do at the hospital is just remarkable. We've had a barrage of surveys recently, and they range in all different areas. So the clinical lab, inpatient psychiatry, the skilled nursing unit, OTOP is happening as we speak. And they support those teams so well, no matter where they are. So I just want to give a big shout out to the quality team. They've done a remarkable job recently. And I also want to really compliment our executive sponsors for the strategic work that we do, Gabe and Jillian and Hemel and Eric. You can see how complicated this work is. And these are very deep and challenging problems, and it's why we have designated them as strategic work. So I'm really grateful to them and the work they lead in attempting to solve these problems and making progress. So with that, I want to go on to the report. First, I'll start with the narrative report. The first 3 items really are about equity. And in each case, our Avon Breast Center, which reached its remarkable 20th year anniversary, the Equity and Innovation grantee, the sensory rooms and healing alternatives, and the Pediatric Asthma and Allergy Clinic. Each of these programs has been specifically designed to meet the needs of the very complex patient population that we serve. And, with Avon, we have the Mamma Van, for example, that goes out into communities to try to connect with populations where we know there's higher risk for diagnosing breast cancer and meeting them where they are. The sensory rooms and healing alternatives. This is an incredibly important innovation, especially for patients in our acute psychiatric unit who end up having to stay a lot longer than they should because they're waiting for an appropriate placement. And then the pediatric asthma and allergy clinic, 25 years of not just treating patients in the clinic, but identifying issues in the home that are important to, actually them having these issues and mitigating them there. So very proud of this work that is being done on campus. We talked a lot about patient access and flow, so I won't address that one here. We'll address it in the statistics as well. I would also like to congratulate Jillian Otway, our official Chief Nursing Officer. She is, she's just an incredible leader and so well regarded by everyone on campus. She really has distinguished herself, especially this year during bargaining, just an incredible leader at a citywide level. So that's wonderful. Angelica Jernigan is in the America's Essential Hospital Leadership Fellow class. This is great. There have been a number of us on campus who have taken advantage of this program, and really glad that she is able to participate in that. And then our Kaizen Promotion Office, these leaders go on to do wonderful things. So examples of KPO fellows from the past, Dr. Hemel Kanzaria, Dave Smith, who is our pharmacy director for the department, was a KPO fellow. Luke Zier, the physician we talked about, who's doing all the work with AI and predictive analytics. So all of these folks, really are focusing on really important projects for the hospital, and I know they'll be wonderful at that. Any questions about the narrative? Okay.
Just one moment.
Yes, of course, Dr.
Dr.
Schaff.
I just wanted to know what status we have then with Terry D'Antoni.
Terry D'Antoni has a new network position. She is the chief for, I don't know the full title exactly, but she's basically making sure that we have educational pathways for bringing nurses and other classifications into the department, and also has a role in care coordination. So she is at the network level with the group of network leaders around Roland.
Wonderful, thank you. I know she did a great job with Laguna, and obviously was highly recommended from you all for Laguna to do that. And I had just wanted to know where she was today, as we have another incredible nursing leader. So thank you.
Yes, we are lucky to have our nursing leaders, and Terry is doing great work at the network level. So one thing I wanted to point out about the data, we have our usual data, and then you noticed some slides that came after the usual data. And what we wanted to do for you was preview the way we're hoping to transition our data report. These data that you've been getting it for a very long time, years. In fact, they predated me. And what we thought would be better is that the data we talk to you about really reflects our strategic priorities. So we wanted to preview this for you so that you would have an opportunity to look at these new charts and make sure that they meet your needs. But in general, what they do is reflect our strategic KPIs. Whereas our old data, though interesting, of course, we always have great discussions about it, they're not a perfect reflection of our strategy. So just to explain that. So I'll go through the first slides that we usually see, and then we'll go through these after that. Okay, so emergency department, you can see that we've had a steady flow upward from 2022, 23, and now the end of the summer. Well, actually, this reflects July of 2024. So we've seen a gradual increase upward in the volume coming to ED. We are the busiest ED in San Francisco. And the admissions, there's a little blip downward, but in general, the admissions from the ED reflect a percentage of the volume that comes in. So leave without being seen and leave without being triaged. I wanted to spend a couple of minutes on this because you can see a very unfortunate trend upward, despite the fact that this is a strategic focus for us. And so the team that's led by Dr. Toph Peabody, who is now our associate medical director in the KPO, has led a really remarkable team in the ED focusing on this statistic, because this statistic and ambulance diversion are the key things that we're following in the ED to make sure that we have good access to our services. So they've done a deep dive into this. There are a variety of factors at play, but by far the thing really impacting this rise is issues with nurse practitioner staffing. So it's very important to understand that in the triage area, the main providers are nurse practitioners. And they are there, well, if we had nurse practitioners fully staffed there 24/7, we feel very confident that our leave without being seen rate would be at the goal that we're seeking, which is 4% at this point. But so our full staffing would be 8.8 FTE. Right now we have 4.8 FTE, and 3 of those people are in FMLA. So there are profound issues. Now they've been escalated to our HR partners and Jillian, and they are working to get folks in as quickly as we can. But it's just, it's an example of where staffing has impacted our strategic work. Diversion. So back in the day when diversion we were struggling a lot more with diversion. So back where this starts in 2022, there were really 2 factors that impacted diversion the most. One was staffing of nurses, and the other was boarding in the hospital, which we've talked about extensively today. I'm very pleased to say that staffing of nurses is really almost never a problem. So as Jillian mentioned, we're almost fully staffed in the emergency department. We do have issues, normally when people call out sick, that would be true in any area, but we're well staffed. The struggles we have is really with boarding. And so when we have fewer patients boarding, like today, we had 10 patients boarding in the ED, which is an unusual day for us these days, we're able to have a much lower diversion rate. So we will continue to work on this, and it's just important to be aware that it really is impacted by boarding and lower level by extension. So the other statistic I wanted to focus on is so the med-surg census, you can see, has been rising. So a year ago, our med-surg census was 175. In July this year, it's 190. So we're definitely seeing an increase that is tied to the lower levels, the number of patients at lower level of care we have. That's not the case in the ICU, fortunately, that we're pretty much exactly in the same place as we were last year. So that really is much more a seasonal structure of demand, which is great news. Also very positive that we're seeing this uptick in our maternal and child census. We do generally have capacity there, and so it's really great to see that there are more babies being born at our hospital. Last year was 1,200, and I know that right around the time when the pandemic began, it was about 900. So we've definitely seen an increase, which is really what we'd like to see. 4A, so you can see the census taking a big drop there. That is really planned. As I believe I explained last time, we have a seismic project that we need to do in 4A. It is much better for every reason that we actually temporarily close the unit and get the work done faster, quicker, and with less impact to our patients. So we are on the path to doing that. We anticipate closing the unit temporarily by the end of September. I believe today the census there was 8 or so. So we're moving in that direction. We want to get the work done in about 6 months, so that you'll continue to see a decline in 4A. We've notified the state that we will be placing those beds in suspension. Okay. There was one other thing I wanted to add about lower level of care, and this graph really says it all. At the beginning, in August of 2022, we had 40. A year ago, 56, and now we're at 88. We talked extensively about it, but there was one other, I know, Dr. Chow, we take your remarks very seriously, and we approach this work very seriously. And the truth is, at the end of the day, there are many things here that are out of our control, right? It's out of our control that there's a lack of affordable housing, which is really at the root cause of a lot of what's happening here. It's, you know, Laguna closing was out of our control. And we are very determined to focus on the things that are in our control. And even if we can't influence them directly, we are going to influence them indirectly. For example, I don't think we've talked enough about our partnership with the San Francisco Health Plan. And I wanted to say 3 things about that, where we're actively working with them. Because they are such an important partner of ours. You heard Eric say, you know, the vast majority of our patients are covered by the health plan. So one thing is about skilled nursing availability. It is widely understood in the community that the health plan doesn't pay high enough rates for our patients, insured by the health plan, to be attractive to any skilled nursing facility. That's not just us. I mean, every hospital in town really experiences the same thing. It's just that we have more of them. So we have been in active discussion with the health plan. Their initial response is, well, the state pays us a rate, and that's the rate we have to charge, or that's the rate we have to pay the skilled nursing facilities. But they do have ability to augment those rates in certain ways. They have incentive plans. They're actually initiating an incentive plan with one of the skilled nursing facilities to make it, to encourage them to take more patients. So that's one thing. The other thing is CalAIM. That is really an important program. And I have directly seen the impact of that with the patients I take care of. So for example, a patient who is in an SRO and has a nurse there who can organize his medications into a MediSet, who can contact me through secure chat and Epic when he has a need that needs to be addressed. Otherwise, that is very likely a person who would have ended up in the emergency department a lot of times, being admitted, and maybe losing his his SRO placement as a result. Case management services, patients who live in their homes, who need somebody to go to their homes, be with them, do the same kind of work. That is really impactful. And there was some of that the health department was paying for, and the city. Now it gets reimbursed through Medi-Cal. We just started this year and this has been in planning for a year, a case management team that is specifically focused on moving patients out of the hospital. That's very important because our patients, if you look at the list of patients and what they're waiting for, a lot of them are waiting to go home, or they're waiting to go to a residential care facility. Why are they waiting? Because they need services that they can't get while they're there. So we need to arrange those for them before they go home. So this is another way that the health plan and CalAIM, through which it's being, health plan is how CalAIM is being implemented. You know, they're contracting for more and more services over time that help us address this. So it does feel like pushing a large boulder up a hill a lot of the time, but our focus is on the things that we can control, like a 9th OR, for example, you know, so we can move patients through the hospital more quickly. And then where can we influence? And the health plan, I think, is a key partner in that. So I hope that was helpful, just a little bit more about our partners in the community. It's a very similar, I mean, it's a similar picture in terms of the trend on acute psychiatry. There we have a very close partnership with behavioral health. A lot of this is about purchasing beds, which they are actively doing, locked beds for sure. Just to say, here, really the state needs to play a more active role. They have pretty much abdicated responsibility in these areas over decades. It takes, fortunately, we don't have many of these patients, but a patient on our inpatient unit who's waiting for a state hospital bed today waits 2 years. So that's what we're up against with the state. But we, again, we're actively trying to do what we can to influence that. Workplace violence, I also wanted to address. The total events are gradually coming down, not as quickly as we would like. I would say that there is another factor here that influences this number, which is that as we've focused more on workplace violence and preventing workplace violence, we've seen reporting go up. So in med-surg, for example, there's definitely more reports, which is great. This is what we want to see. It allows us to address them. So, that is also influencing these numbers. The focus we've had in the emergency department and PES has been very successful. We've seen those numbers come down. Now we're focusing in med-surg because it's a different approach we need to take because it's a much larger area and the BERT team covers that in a different way. So we'll continue to focus on that. Okay. I'm going to stop there and see, well, I can actually, why don't I go through the rest of the slides just so you can see the new ones that we've created and then we can have questions.
Yes, that would be fine.
Okay, great. So this first one is departments driving equity, and this is a metric we've followed for quite some time. You've seen it on our scorecard. So every month we see the departments reporting to PIPs who have selected a driver related to equity. And so that's why you see this change from month to month, is because each month we have a different set of departments that is reporting. But generally we're meeting our target. We have been for quite some time, which is really great news in terms of driving equity. Sepsis bundle compliance, we have, I'm eager to show you the work that we're doing in this area. There's a very robust team that's been put together to drive improvement in this metric, but it hasn't started yet. We just put the graph here together for you. Hospital-acquired pressure injuries we've talked about, and you can see we have a really good story to tell here. Falls with injury. So those are our, the HAPI, sepsis, and falls with injury is the bundle we follow in our safety initiative. Moving on is our flow and access, which you heard about today. So you can see the diversion rate over time, left without being seen, the percentage of add-on cases that we're able to complete, third next available appointment in our specialty clinics, and lower level of care and the Department of Care Coordination. That's the bundle for our patient access initiative. And then departments driving staff engagement, that's a new metric that we'll talk more about. This is going to be very synonymous with our equity work. So we're hoping to drive that through our PIPS committee. Physical assaults with injury, we just talked about. So those are the two metrics for our staff engagement initiative. Denial rate is our financial stewardship one. And then the star rating, likelihood to recommend hospital to family, friends and family, likelihood to recommend provider's office to friends and family, and likelihood to recommend ZFSG as a workplace, and the general fund spend. These are all our true north metrics that you see at the bottom of our scorecard. So those are the new metrics that we are proposing to share with you every month. And then we have just further detail about our lower level of care, both on med-surg and psychiatry, diversion, borders in the emergency department, and our med-surg occupancy rate as expressed as a percentage. So those are the new metrics. And that's it. I'm happy to answer any questions.
Thank you. Let me begin from Commissioner Christian this time.
Thank you, Dr. Chow. Dr. Ehrlich, thank you for the presentation, and I appreciate your framing of the focus that you are placing on the things that can be influenced while not losing sight of the, and not letting us lose sight of the things that we can't influence directly but need to be addressed and will never, until they are addressed, the need won't go away. So thank you for that. I like the new metrics, the slides, so thank you. And excellent work, great presentation. Thank you for the clear and concise presentation of a lot of work and a lot of detail within that. Always happens, and it's always really helpful. Thank you.
Thank you.
Right. Thank you. So I'll go on to Commissioner Green.
Well, I can't say it any better than Commissioner Christian did. I completely appreciate the work and all the intricacies involved, and I really do like the new presentation.
Great.
Very wonderful, really wonderful.
Much. I appreciate that. And we're happy to take comments. We have, a couple weeks before we start again with next month. So would really appreciate any input you have about how we present this next time. And thank you so much for the gratitude. It means a lot for your support.
There's a lot of it. You always tell us, and it's always true. You have such great staff, and it's one of the primary pleasures about being here and hearing from you is learning all the ways that is true, and new ways and old ways, but the information is great. But the work that people are doing under difficult circumstances is really very impressive.
That's why we all come to work every day, take care of our patients. Thank you.
Yeah, I would agree that the presentation on some of the topics in terms of the new scorecards and the deeper dive in the lower level of care are very nice. I think that we still cannot lose sight of the quantification of how many people are in the hospital and the emergency room activities, because I think that numbers are also important to know what the volume is coming through. And so maybe it's an amalgam in which some of the documents are, more expanded in your new scorecards and don't really have to be there. But I think like activities indicating the volume within the emergency room and how that is going, and it can continue to be presented to give a overall picture of what is the quantity of people that we are really moving through the hospital, and therefore part of the challenge of who still is getting lost and not going anywhere. I think that's really important for us to realize. And so an amalgam of the two where you are taking a deeper dive in things like a diversion or length of, is fine. But I don't think we can lose sight of the demographics.
Okay, that's great feedback. Thank you.
Okay, so we'll look forward to seeing how they get merged and without duplication, and therefore how we can, have a deeper dive at those other questions that, of course, today we've all taken up. And it's a great background for being able to watch new, I guess, parameters in terms of where the hospital then is also performing. So thank you very much.
Great, thank you.
And actually, Commissioner Chow, if I may dig a little deeper to that. So is it possible for the hospital to report those on the quantitative data on a quarterly basis versus monthly? I'm just trying to think of staff time, because I'm assuming that's part of that's workload, right? There's staff goes into that, or are those automated reports?
I mean, the volumes are
Well, you be doing volume daily, so it's just simply. I think personally it needs to be tracked monthly.
Okay, I just want to clarify to make sure we
Yeah.
were.
Thank you
was-
for
No.
your acknowledgement of the workload. But we'll take the feedback and then come back with a new report.
All right,
Thank you.
thank you. Let's move on to item 7, the hiring and vacancy report.
Good afternoon, Commissioners. Mark, Emma Press, Clinical Hiring Team Supervisor. We wanted to share our hiring status. So the hospital vacancies increased slightly to 7.93% compared to 6.39 last month. We have, as you've heard, new positions added to the budget, which has made our vacancy rate increase. And you'll see that in our graphs as well. We have hired 35 employees in the month of July, various classifications, and we had 9 separations during that period, of which 2 were retirements. We have 53 positions that have been added as RNs in the budget. And so we continue to move forward with our hiring processes. We hired 10 nurses in July, including reassignments. Three per diems were added in the month of July at Zuckerberg. And as you heard from Jillian, she kind of stole our thunder, but it's great because we really do have a partnership to listen to nursing leadership and their specific needs to be able to address some of those challenges. So we have a hiring event scheduled in September, and we hope to fill many of these new positions, if not all, from the hiring event. We actually have worked with nursing leadership to make sure that they also have the ability to hire before then, right? Not wait until September, but if they're able to make selections before then and then identify any additional candidates that they want to invite to the hiring event. So we're going to have a great time having the candidates come through and meet nursing directors and get to chat with them and see what the nurses do on a daily basis there and the great culture at Zuckerberg. We've also have in place a new RN reassignment process, which allows hiring managers to post job flyers with specific job information at time of vacancy. So that's a great update for nurses to be able to see in real time, what the attributes of the position are, if they're interested in the FTE, the location, all of that information. And hiring managers are able to do both processes simultaneously. So they get to have access to the eligible list while they're waiting for the reassignment candidate or the flyer to be completed. And then they get to see both pools and manage that process simultaneously. We continue to meet with nursing leadership. In fact, there's a RN planning committee that meets weekly to discuss any challenges in hiring and making improvements. And we also meet with leadership to understand, what's worked and what could still use some improvement. As far as RN hiring updates for the emergency care, we have 7.9 FTE vacancies. They've made 2 selections so far with some start dates in August. Critical care has 10.4 FTE with 4 selections made with start dates in August and September. MedSurg has 21.05 FTE vacancies, and they've made 3 selections with target start work dates in September. The OR has 1 vacancy with the selection pending. And again, some of these are the new positions that are being added, so we hope to fill them either at the event or prior to that. We do anticipate a neonatal training program starting in October, and we will open new training programs based on need. We also are hiring other job classes. So we've hired 3 2903 hospital eligibility workers, 2 2471 radiological technologists, 1 2548 occupational therapist, 2430 medical evaluations assistant, 2930 psychiatric social worker, among many others, but here's some highlights of those. So wanted to see if you have any questions.
There's no public comment for this item. Oh, Commissioner, you're muted.
Sorry. So let's start with Commissioner Green today. Any questions on the HR report?
Well, thank you so much for re-thunderizing because I think it's really great what's going on. I had two questions. One is the 23-28 category your nurse practitioner, when you spoke about the issues in triaging patients in the emergency room, is that the category that speaks to those vacancies?
That's correct. I believe Dr. Ehrlich mentioned the 23-28 nurse practitioners are used there.
And because you've only got 7.6 open, and I think a majority of them are emergency room positions. Is that a challenge in the way that it had been getting emergency room nurses? In other words, is that position one that only individuals with real interest in the PACE would take?
That's accurate. So, nurse practitioners specialize in a different area. So we have to post specifically for the area, that the position is available for. And so it is difficult to recruit the nurse practitioners in specific specialties. And so, we have recruiters who are assisting with that. But as Jillian mentioned as well, while we're looking at what we've done with the RN hiring and trying to implement some of those improvements in other job classes, we really have to adapt those improvements to the job class because, they have their own specific challenges. It might be we don't have a large candidate pool available. It might be the specialization in that role. So we have to adapt it to make sure that it's meeting the needs for that specific job class. But we are looking at what can we do. Some of these like hiring events may be focused on specific job classes, which I don't know if one of those will be nurse practitioner, but it could be. So they're looking at all of that. The team that's meeting weekly to address that is now focusing on each job class to see what can be done by class.
And then the other one, I wondered in terms of some of the other information about flow through the OR, which I know is a really important parameter, was the 2310. So those are the surgical procedures technicians. I don't know if they're the people that scrub if RNs aren't, but is that what that category is? And I wondered whether that, you see a 37%, I think that was the number of vacancy, but I'm not sure how that affects the flow in the operating room and the ability to get cases on. Is that does that number have a meaningful impact in the overall operations of the operating area or not?
I would have to go back and look at where those positions actually sit. But I know that there's also a lack of, well, at least from my historical information, I don't have current information. It is also difficult to recruit individuals who have the certification for that job class. So I can go back and look at that information and bring it back to you to see if there's an impact specifically to the OR.
Yeah, we've had that problem as well. And the surgical techs are terrific, but I know we sometimes have to have labor and delivery nurses scrub on sections, and it's a real challenge, and it affects all the staffing all the way down, and we can't run two rooms. I mean, it does become a big issue with at least the flow that we experience when you have a dearth of tech. So I was just curious whether, if they're 37% vacancy, but there are only 5 of the people that work there, it's a different worry than if they're really integral, like they're integral to our system, but they may not be as integral to your larger OR.
I believe they are. I mean, if it's the vacancy, right, we need that person there. We need to fill that position. So yes, they are all, the positions are integral to operations. I just don't know the specific area. I would imagine that they're in the OR, but I don't know if it's that if they're anywhere else. So I just want to go back and look at that.
Thank you. Those are the only questions I had. And obviously, the way these positions are being filled, we've said many times, we're beyond our wildest imagining not too many months ago. So it's really remarkable, the creativity and the approach and the outcomes you've been able to produce with all of this innovative thinking you've done. So thank you.
Yeah, it continues to be a very nice report. Commissioner Christian?
Thank you. I just want to echo what Commissioner Green said and acknowledge and thank you for the creativity that you've shown over the last year and the gains that you've made. And so just want to acknowledge that and praise you for that and thank you.
Thank you.
Thank you. It's really nice also to see your graphs and how we've actually been able to overcome the previous year's issues. So Again, thank you.
You're
Mark, shall we go on?
Yes, thanks a lot, Emma. And you know what? If you're able to find that information, you can just email it to me and I can forward it to the commissioners instead of you bringing it back to the meeting next month, and however it works for you.
Sounds good. Thank you so much.
Sure, of course. Let's move on to item 8, the medical staff report.
Good afternoon, commissioners and Mr. Moritz. Mary Mercer, I'm the chief of the medical staff. It's nice to see you in person this time. So I'll be presenting our medical staff report, which highlights the work of our neurologic services report and their rules and regulations. So I will just start to draw attention to the rules and regulations. Were mostly administrative changes, but the theme that was highlighted were really clarifying the roles and responsibilities of the attendings on service and the responsibilities to offload the residents, and just to highlight that our regulatory entity, the American College of Graduate Medical Education, has evolved over the last number of decades to have very strict rules and regulations around work hours for our graduate medical trainees. That also has implications for the work and duties of our attending services across the board, and in this case, the neurology service. And I think that's overall is a very positive culture shift in terms of having the buck stop, if you will, with the attending of service. But it does have other implications, which I think were highlighted in the neurology report. The neurology service report had a great deal of opportunities for celebration of the tripartite mission that service really serves. And I will highlight a couple of key things here, just notably all of the performance improvement work over many, many years to improve access and timeliness of care for stroke and for neurologic emergencies. And you can see actually, I think in their performance improvement area that they had a over 1.5 increase in number of ischemic strokes, for example, that are served in our institution, while also at the same time reducing the time by nearly a third for definitive care, which ultimately leads to better health outcomes for our patients and community. Just again, highlighting the interdisciplinary nature of that work that I get to see every day in the emergency department as well. I think there was a question around in the report that there were implications for all of this work that has had increased complexity, increased scrutiny and timeliness in terms of raising the standard of care nationwide and locally. And that has, challenges for the increased work demands on our faculty. And I think there was a question around recruitment and retention. They have done a great deal to improve recruitment and retention of faculty by increased salaries. And I think Commissioner Green noted the question around nurse practitioner staffing to help support and offload some of the physician workflows. And that was highlighted in that report. And we're very encouraged by all of the hiring improvements that have been made. And hopefully that gap that has been existing on that service will close, not just for nurse practitioners, but for other classifications. I think EEG technologist was one of them. I'll take any questions.
Thank you very much for your presentation and the report of the neurology report there. Commissioner Christian, to start with you, any questions to Dr. Mercer?
Thank you. I have no questions for you, but do want to thank you for the work. It is so important and so critical, and thank you for doing it so well.
Okay, and Commissioner Green?
Well, yes, I mean, it's a remarkable department, as we're always so inspired by these reports that we hear from every division. And I guess the one common theme, which thank you for answering, is this concern about burning out attendings, which, I think one of the departments, I can't remember, was trauma or urology. They were like 80 hours of call. I mean, something really intense. And, how that balances against these critical needs to satisfy the graduate education stipulations, which I remember, I think there was a threat at one point to decertify the family medicine program and a few others. So I know San Francisco and maybe the general in particular has kind of been scrutinized in that area. And so just, was very happy to hear that. I mean, obviously it's a focus, but it is a concern. And I don't know how it's a challenge, certainly in every area. We compete with Kaiser and, to try to recruit people here with the cost of living and, the challenges of affording this place is really difficult. And I know UC has grand designs to expand, especially as they're taking over the Common Spirit hospitals, to expand the provider base. And I will be very interested to see how that's accomplished, given some of the barriers to having a middle-class lifestyle in San Francisco. So thank you so much.
Thank you.
And I want to thank you also in again providing the PowerPoints, because they really give a very fine explanation as to your summary. And I found it that the residency program restrictions continues to really haunt us in almost every department. And I don't know if anybody actually has done a study or studies that this has been good or bad in terms of the outcomes and the training that our trainees are getting with this type of limitation. So does anyone, Dr. Ortiz maybe or Dr. Mercer know if there have been studies that this has really been a good thing as versus what probably most of us have gone through, which was a somewhat more rigorous on-site hours, right, that we've all experienced.
Thank you for the question. It's an excellent question. I think there are certainly concerns around making sure that we maintain enough volume and diversity of cases to have adequate training. However, I think the literature to date has been, and what has motivated a lot of the regulatory changes has been motivated by patient safety issues that came up with sleep deprivation and other challenges over time. And so I think overall, the changes in the GME are positive and are patient-centered, as well as workforce centered, that we need to maintain a workforce that is sustainable. And now we're seeing more attention being paid on to carry over some of those findings to the attending physician workforce as well, which will require a full team, the village effort to really maintain the high quality of care and diverse services.
Well, thank you very much, and certainly this again, as I said, the PowerPoints help put a fine tooth comb upon the challenges and the fact that the next challenges rising in many of our departments are with the attendings and a need to assist them. And sounds like a solution coming up here with the neurology department trying to bring in a nurse practitioner to help. So that sounds is very helpful for us to understand the challenges of these departments. So thank you for your report.
Dr. Cho, if I might, I do have a question and a comment. I wondered if you could say a little bit about the Balance Initiative, and it's a very interesting and important one.
Yes, and I can't speak as well about this as our service chiefs can, but again, I think what the Balance Initiative does highlight, and this is also as we compete for other neurologists or other physicians across San Francisco and the Bay Area, I think this highlights one of the unique and special things about our institution and why we do spend a lot of time in the recruitment process to make sure we have right fit faculty, but also people who are mission driven in terms of a global purpose, in terms of serving the causes of health equity. So the Balance program is really addressing neurology and global neuroinfectious diseases. And we have a unique population that we serve in San Francisco, both for our infectious disease expertise, but also from our diverse groups of patients that come from all over the world, that then some of the advances that we have made here in San Francisco are also carried elsewhere globally. And I believe actually Dr. Hempel, who I tracked down for some of the questions, is currently in India, presenting on some of these issues right now.
What an important initiative, and something that equity in this area is desperately needed, and something I hadn't really heard about before. So I look forward to hearing more about it and definitely applaud you for this work.
Thank you very much.
Okay, thank you. Mark,
Well,
are we
there's a
on?
vote. A vote is needed on the rules and regs.
Yes. Okay, so we need a motion to accept the revision, recommend to the commission the revisions in the neurology department rules and regulations.
So moved.
Second.
I will do a roll call vote. Commissioner Christian, how do you vote on this issue?
Yes.
Commissioner Green?
Yes.
And Commissioner Chow?
Yes.
All right, thank you so much. That'll be put on the consent calendar for the next meeting. We can move on to item 9, other business. Hearing none, we can move on to public comment. We have no public remotely or in the room. So commissioners, please consider a motion to go into closed session.
Motions in order for closed session.
So moved.
Second.
I will do a roll call vote. Commissioner Chow, how do you vote?
Yes.
Commissioner Green?
Yes.
Commissioner Christian?
Yes.
All right, please give me 30 seconds to transfer us. Oh, let's see. An open session. Commissioners, please consider a motion to disclose or not disclose discussions held in closed session.
I move that we not disclose discussions held in closed session.
Second.
Commissioner Green, how do you vote on this issue?
Yes.
Commissioner Christian?
Yes.
And Commissioner Chow?
Yes.
Okay, great. Now we're at a consideration for adjournment.
So
Motion
moved.
Second.
All right,
Second.
Commissioner Chow, how do you vote?
Yes.
Commissioner Green?
Yes.
And Commissioner Christian?
Yes.
Thank you all so much.
Thank you.
Thank you.